Hey guys, thank you for joining in. I see Sahar, Tim, and Iyad joining in from West Bloomfield and Vina. I think we'll probably give it another minute and then we can get starting the lecture. So we have our senior staff from Henry Ford Downtown, Dr. Williams, with us. So a lot of our observation folks know him from our rounding in the unit. He's been very helpful right from the time he was a fellow here. So we have him here to give us a lecture on infectious disease management and observation, which has been a sort of a rough topic. We've never really covered this as a topic together, so it'll be wonderful to see
All right. Thank you.
people join. So I think we can go ahead and get started.
Okay. All right.
All right.
All right.
Yeah, Jonathan, go ahead.
Okay. Sounds good. Thank you, Dr. Bright. And hello to everyone. My name is Jonathan Williams. I'm senior staff physician in infectious disease. Currently mainly rotate here downtown, but in the spring I will be beginning rotations out in West Bloomfield. So those of you who are mainly on the West Bloomfield, I look forward to meeting you at that time. I do not have any disclosures. And, you know, the discussion today, we'll talk about acute bacterial skin and skin structure infections, urinary tract infections, and pneumonia. So we'll go ahead and get started. So when we're talking about acute bacterial skin and skin structure infection, you know, we have to think about the anatomy of the skin. And when the top layer of the skin or the epidermis and dermis, typically in an infection in that area is, you know, we typically classify that as being erysipelas or cellulitis. When you start going deeper into the follicles of the hair, like hair follicles, then you are, you know, beginning to develop what we call, you know, furuncles and carbuncles, and usually like pustular formation around the hair follicles. And then below that, in the subcutaneous tissue, deep fascia and muscle area, that is the term that we use to classify as a necrotizing fasciitis and myositis when there's infection and inflammation of the muscle. And as you can see, looking at the organisms that are listed, the most common organisms to cause infection of the skin and skin structures are gram-positive organisms, strep, staph being the most common. But that doesn't necessarily mean that, you know, gram-negatives or enterococcus doesn't cause infection. They do, you know, less often than strep and staph, but in patients who are, you know, immunocompromised and, you know, typically in deep skin structure infections like neck fascia, myositis, because those infections tend to be more polymicrobial, then, you know, that's when you're beginning to see more of the gram-negative bacilli. So, you know, distinguishing between cellulitis and erysipelas. So erysipelas is, you know, infection of the top, you know, superficial dermal top layer of the skin, and is characterized by being very well demarcated. That is the, you know, hallmark characteristic that separates it from cellulitis, as you can see, which where it's, you know, more diffuse, is not as well demarcated as an erysipelas. It tends to be a very bright red on examination. And this erysipelas is typically caused by streptococcal infections more so than staph infections. So that's why we do try to, and, you know, delineate between erysipelas and cellulitis, because that will affect our management when it comes to antibiotic selection. Because in the cases of erysipelas, we're less concerned about covering Staph aureus. So, I mean, cellulitis is relatively common. I'm quite sure you guys see it quite often. And again, strep and staph are the most common. Strep more so than staph actually, but staph aureus is common here in the U.S. And typically, risk factors that are associated with cellulitis and erysipelas infections is, having breaks in the skin, so having trauma, incisions, ulcerations of the skin. Patients who have stasis dermatitis are at high risk. Patients who have tinea pedis are at high risk. So, often when we're going in and evaluating these patients, I often, look in between the webs of the toes to see if a patient has a tinea infection in there. Because if that is the case, we often recommend to treat the tinea infection along with the cellulitis, because that is an inciting factor or for cellulitis and have a recurrence of cellulitis. So, we do look for tinea, especially in lower extremity cellulitis. Also being obese, having diabetes, patients who have venous insufficiency, and patients who have disruption of the lymphatic drainage system, or who have issues with the lymphadenopathy. So most commonly we see cellulitis and erysipelas in the lower extremities, and it's characterized by skin warmth, edema, erythema of the skin. It can have like an orange peel appearance, especially in patients who have associated lymphangitis. It can be associated with vesicles or blisters. As you can see up here, you can have bullous cellulitis. It can be associated with petechiae, ecchymosis. So, and it's often present very similar to other things like gout. So when we have a patient that's presenting or you're concerned about cellulitis or erysipelas, we often have to think about, could this be gout? Could this be a vasculitis? Could this be some sort of, viral xanthum, or there is the erythema migrans, or contact dermatitis. We've often been consulted for concern of cellulitis, and we've diagnosed gout, and we've diagnosed contact dermatitis. So I would encourage you to keep those things in mind when you're evaluating a patient for concern of a cellulitis or erysipelas infection. Also, as well, when you're evaluating these patients, you should look and see if there's any associated septic arthritis of the joint, or bursitis or osteomyelitis if it's an open wound. So when talking about diagnosis, is mainly based on history and physical examination. Sometimes you can see elevated white blood cell in these patients. Sometimes the CRP, ESR may be elevated. Something I do want to point out is that, getting routine blood cultures on patients who are presenting with a cellulitis or erysipelas infection is not recommended. And that's because less than 5% of cases will have an associated bacteremia. And oftentimes we pick up skin, contamination when we're just routinely checking blood cultures in these patients. So if the patient is not septic or doesn't have any hemodynamic instability, I would highly encourage you not to check any blood cultures in these patients. And cultures of intact skin, so like a chronic ulcer, is usually not helpful as well, because all you're going to do is pick up, skin contaminants, and it's kind of hard to distinguish whether this is just a skin contaminant, or is this the actual bacterial that's causing an infection. Um, Also, when evaluating these patients, if the patient doesn't have any cultures in the system, like a previous blood culture or a previous history of having MRSA, and you're trying to decide on if you want to start, do you need to start MRSA coverage like vancomycin, we would often get a MRSA nasal culture, because if they're not colonized with MRSA and they don't have any purulent discharge, then less likely that we need to target our antibiotic therapy for MRSA. If there is a purulent discharge, like there's an abscess or a furuncle or carbuncle or a bullous cellulitis, we would recommend that you try to get cultures. So unroof a vesicle, or if there's anything draining, clean the skin around the area and express the pus and culture it. And oftentimes when we do that, we're able to isolate an organism and be able to narrow and target our therapy to that particular organism. So, when you're evaluating these patients, it is recommended, and it is a good idea to check for risk factors for MRSA. So, is this patient, household or daycare, contact of a patient with a proven MRSA infection, children, men who have sex with men, military personnel, patients who are incarcerated, athletes who participate in contact sports like wrestling, Native Americans and Pacific Islanders, patients who have a history of MRSA infection, IV drug user, hemodialysis. These are the patients where they are high risk of having colonization with MRSA. And so, in that case, this would be the situation where you would potentially think about empirically starting medication that it target MRSA, such as vancomycin. So I do want to stop and take time to talk about necrotizing fasciitis, because it's very few infectious emergency, like infectious disease emergencies, in the sense of where something emergent need to be done. But necrotizing fasciitis is the one infection where it is considered to be emergent. It usually presents with pain out of proportion to the findings. So, someone may have just mild erythema. It may just be, slightly warm, but when you touch the leg, or usually the leg, then, they're like just the slightest touch, these patients are jumping out of the bed, they're in excruciating pain. There's also, they have induration, or, hardening of the skin beyond the area of the redness. Sometimes they may have a crepitus or subcutaneous gas that can be palpated, and it usually presents with a rapid progression of the skin findings. Sometimes they may have systemic toxicity, such as tachycardia, hypotension, that may go along with it. And sometimes they may have paresthesias, where they start having numbness and tingling in parts of their extremity. Sometimes it can present as very dusky. Sometimes they may have bullae. When we see these findings, that is very, very concerning for necrotizing fasciitis. Sometimes it may be more subtle than that. There's a scoring system that was developed that you can use in conjunction with your clinical examination. called the LYRINC, which if you have a score of greater than 6, it has a positive predictive value of necrotizing fasciitis of 92%. So, you know, elevated CRP greater than 150, a leukocytosis of 15,000 to 25,000, hemoglobin of 11 to 13.5, hyponatremia, and a serum glucose greater than 180. So, you know, this is the time when, you know, if this is greater than 6 in the clinical findings, and also imaging may show subcutaneous gas or fascial edema. So with all of that being said, you know, this is the time where you will actually call the surgeons to come and evaluate this patient very quickly because the patient needs to go to the OR right away. So that's why it's very, very important in patients who are presenting with a skin and soft tissue infection that we have to be very cognizant, and we have to look for necrotizing fasciitis. It's a diagnosis that we don't want to miss. And the sooner that the patient can be diagnosed, and the sooner that they can get to the OR, that gives them a better chance of saving their limb. So coming to the management of skin and soft tissue infections, this algorithm comes from the IDSA guidelines for skin and soft tissue infections, and this was in 2014. And so how the IDSA breaks it up is into 2 categories. So you have non-purulent, and then you have purulent. So purulent is, you know, furuncles, carbuncles, or abscesses. And so in this case, you know, you would try to get IND, try to get cultures and sensitivities. And if it's mild, a mild case of a carbuncle, furuncle, or an abscess, just IND alone and no antibiotics is the treatment. If it's more moderate, you will do IND, culture, and sensitivity, and it is recommended to start empiric oral antibiotics such as Bactrim or doxycycline to cover, you're targeting MRSA in this case. And, you know, once the culture results come back, you can make adjustments. So if it's come back as MSSA, then you can switch to a penicillin or cephalosporin such as dicloxacillin or cephalexin, or other name is Keflex. In severe cases, you want an IND and also start empiric IV antibiotics, vancomycin, daptomycin, linezolid. Again, in this case, you're targeting MRSA because the studies have shown that when you have a abscess or any type of purulence that's associated with a skin and soft tissue infection, that Staph aureus, in particular MRSA, is the more likely etiology, more so than streptococcus in that case. And then moving over to the non-purulent side, which is probably what you'll see more often than not in the observation unit or somebody being hospitalized. So if it's mild, it's recommended to target your therapy towards streptococcus and MSSA. With penicillin VK, you can use a cephalosporin such as Keflex, dicloxacillin, or clindamycin. In more moderate cases, IV antibiotics, again, still targeting towards streptococcus, penicillin, ceftriaxone, you can use cefazolin or Ancef or IV clindamycin. And then in the severe cases, severe meaning that this is a deep structural tissue infection like a necrotizing fasciitis or myositis. In that case, we're empirically treating for MRSA And then this is where we, as in the first slide that I showed you, that's when the gram-negative bacilli, such as Pseudomonas and other Enterobacteriaceae come into play. And in that case, we want to cover with something like piptase or ozocin, and you're going to call your surgeon. So, typical cases of cellulitis without systemic signs of infection. So that is what's defined as being mild. And again, as in the algorithm, the antimicrobial agent should be targeted more towards streptococcus. So again, penicillin medications like amoxicillin, dicloxacillin, augmentin, cephalosporins such as Keflex will be more than appropriate. For cellulitis with systemic signs of infection, systemic meaning like we maybe have fevers, maybe some tachycardia. Again, streptococcus is more likely to be the etiology than Staph aureus. And in that case, you could start with IV cefazolin or IV or IV penicillin, IV penicillin. And then, de-escalate into something like oral amoxicillin, oral Keflex. And the reason why they recommend this, and it's coming from the IDSA guidelines, is because when they looked at the studies, they did a study of a randomized controlled trial where they gave patients who had non-purulent cellulitis either Keflex alone or Keflex plus Bactrim. And what they found was that Keflex plus Bactrim did no better, meaning that the time to resolution of infection, mortality, morbidity, time spent in the hospital, they did no better than those who received Keflex alone. And with that being said, they recommend, because they, and also the cultures that they were able to obtain showed that these patients, most of the time, were not colonized or did not have Staph aureus infection. So therefore, it's not recommended to routinely target antibiotics towards Staph aureus, such as giving medications like Bactrim. So for patients who have cellulitis that's associated with a penetrating trauma, or if they have evidence of MRSA infection elsewhere, such as nasal colonization, and this is where we come in with doing the nasal cultures, or if they're injection drug users, or if they have SIRS, severe, coming in with severe SIRS, fevers, high tachycardia, then, empirically starting off with vancomycin and targeted MRSA therapy is recommended in this case. And just to kind of reiterate what we just talked about, this is a table with the recommendations of antibiotics for skin and soft tissue. So over here we have the disease entity. Impetigo is, typically you don't see that in adults, that's more so in children. So for MSSA, skin and soft tissue infection, IV nafcillin or oxacillin or cefazolin is recommended. Clindamycin, dicloxacillin, cephalexin, doxycycline, minocycline, Bactrim can be used in these patients. And doxycycline, minocycline, Bactrim, or clindamycin, if a patient has a beta-lactam allergy, like if they have a penicillin allergy, then the alternatives, you could use something like doxycycline or minocycline. But for MSSA and for streptococcus, penicillin medications are the drugs of choice, penicillin and cephalosporins. The alternatives such as doxycycline, minocycline, and clinda, I would, we usually reserve that for patients who have a penicillin or a beta-lactam allergy. And for MRSA, skin and soft tissue infections, vancomycin, daptomycin, ceftaroline, which is a fifth generation cephalosporin that has MRSA activity, can be used. Dalbavancin or ridavancin, which are newer agents, which I'll briefly talk about. And then for on the oral side, clindamycin, doxycycline, minocycline, Bactrim, azolite, and tadalafil are options for MRSA skin and soft tissue infections. You may be asking, how do we choose out of all of these options? So part of it is, sometimes like provider preference. But for example, if a patient has, chronic kidney disease, they have hyperkalemia, I would try to stay away from Bactrim, so I wouldn't use that. For example, if a person is on a antidepressant medication and they have they're on an SSRI, then I would avoid linezolid because of the interaction. Clindamycin, me personally, I don't really like clindamycin that much for MRSA because here in Detroit, we have such a high rate of resistance. The skin infection, I typically go with the tetracyclines. They're fairly well tolerated, don't have too many side effects. And the MRSA coverage is about 90% here based on our most recent antibiogram. So I typically like using tetracyclines such as doxy or mino. So, that's how, the rationale as far as which medication to pick is kind of based on the, what other medications the patient is on, what other comorbidities like renal function, and also too sometimes based on provider preference. So these are two of the newer, both of these medications were approved in 2017. And they are approved for skin and soft tissue infections or acute bacterial skin and skin structure infections, in particular that are caused by gram-positive organisms, including MRSA. So both of these medications are in the glycopeptide antibiotic class, so in the same class as vancomycin. Vancomycin is also a glycopeptide. So dalbavancin, as I just told you, is FDA approved for the treatment of adult patients with acute bacterial skin and skin structure infections caused by gram-positive organisms. The unique thing about dalbavancin is that it has a very long half-life. It has a half-life of 14 days. And is usually it can be given as a single dose of 1,500 milligrams IV one time, or as a 2-dose regimen of 1,000 milligrams IV on day 1 and then on day 8. Ridavancin or Bactiv, it also has a long half-life, and it's indicated for the same thing as the dalbavancin, for skin and soft tissue infections that are caused by gram-positive organism, including MRSA. Its half-life is long as well, 10 days. And this is given as just one single dose. And so, one dose of each of these medications is equivalent to a full course therapy for a skin and soft tissue infection, like a 7 to 10 day course. And the problem with the medication is that at this time, is only approved as an outpatient. They are both very expensive, and they usually require prior authorization. So, you know, where we kind of position it at is if someone who, you know, so let's say if you have someone that's in the OBS unit and you're concerned about, you know, compliance and you don't think that they are going to take the medication, you know, let's say they're like a drug user, you're concerned that they're not going to take a 7-day course of Bactrim, then in that case, you know, this would be an option. But the problem that we will run into is trying to get prior authorization. And then if they do get authorized, they have to be discharged, and then they have to go over to the infectious disease clinic and get the infusion. But, you know, it is an option. So coming to duration of therapy, shorter is better. So if you have prompt clinical response, then it's recommended just 5 days of antibiotic therapy to take care of cellulitis or erysipelas infection in particular. If there's delayed clinical response or they develop cellulitis or erysipelas during a neutropenic fever episode, which we often see and sometimes in our cancer patients, then a 7 to 14 day duration of therapy will be warranted at that point in time. You know, when it comes to necrotizing fasciitis and myositis infections, the duration of therapy is going to depend on source control. So there's no set recommended therapy. It's sort of based on, you know, clinical expert opinion and, you know, how much of the source has been controlled. So sometimes if they, you know, if the surgeon can go in there and clean everything out, or if they have their limb removed, then maybe just, you know, 5 to 7 days of antibiotic therapy post surgery is good enough. Sometimes it may go longer if source control haven't been achieved. So I want to, at this time, kind of transition to start to talk about urinary tract infections and pyelonephritis. So just to start off with some basic definitions. So cystitis is a syndrome involving dysuria, frequency, urgency, and occasionally suprapubic tenderness. So this is basically an infection of the lower urinary tract or a bladder infection. A complicated urinary tract infection is infection of the presence of factors that predispose to persistent or relapsing. So if there's some sort of anatomical abnormality that a patient has, like ureteral stenosis, they have, you know, stents in place, renal stones, women are kind of fall into that category, then, you know, that's considered a complicated urinary tract infection. And then acute pyelonephritis is characterized by flank pain, tenderness, or both fever, and often associated with dysuria, urgency, and frequency. So basically, upper tract, you know, you're thinking of an infection in the kidney. So, what patient populations are at greatest risk for urinary tract infections? So premenopausal adult women more so than men, and that's due to the anatomy. People who have women who have sexual intercourse, women who use spermicides, pregnant women, and people who've had previous urinary tract infections are at greatest risk of urinary tract infections. Other patients, diabetics, again, people who have neurogenic bladders, spinal cord injury, pregnancy, patients who have prostatic hypertrophy, or patients who've had recent urinary tract instrumentation are also going to be at risk for urinary tract infections. So in uncomplicated or cystitis and pyelonephritis as well, E. coli is by far the number one organism causing urinary tract infections. And then we have Staph saprophyticus. So Staph saprophyticus is a coag-negative staph that causes urinary tract infection. And typically we see these Staph saprophyticus infections in young women. Other organisms that commonly cause infections in the urinary tract are Klebsiella, Proteus. When patients have short-term catheters in place, then other Enterobacteriaceae such as Citrobacter, Enterobacter become more prevalent, and then also Pseudomonas, Enterococcus, and Candida become more prevalent when there's a presence of a catheter in place. And the same thing if you have a long-term catheter as well. To kind of go in more detail about what is the definition of a complicated urinary tract infection. So if diabetes, pregnancy, symptoms for 7 or more days, hospital-acquired infection, having renal failure, urinary tract obstruction, renal transplant patients, presence of a indwelling catheter, stent, nephrostomy tube, recent urinary tract infection, urinary tract instrumentation, or if there's any type of urinary tract anatomical abnormality or being immune suppressed. All of these, having any one of these makes you fall into the category of having a complicated urinary tract infection. So I kind of want to transition into talking about altered mental status and UTI, because we often get consulted about urinary tract infection in patients who present just with a altered mental status. And so most of the times these patients don't have a urinary tract infection. They usually have altered mental status due to some other reasons, such as being being dehydrated, oftentimes because of polypharmacy or new medications that have been added on. So if a patient has elevated white blood cell count greater than 10,000, they're hypotensive, their temperature is elevated, respiratory rate is elevated, white blood cell count elevated, and they have bandemia, then yes, at that time, and they can't give you a history, then yes, we would say yes, obtain a urinary analysis and urine culture. And if it's positive, we would recommend to treat. But if they don't have, any of these features, then we would recommend to hold off getting a UA and a urine culture and try to look for alternative causes. Because these patients who present with altered mental status, studies have shown that we're over-treating these patients with antibiotics, and we're, causing more harm than we are causing any benefit to these patients with exposure to antibiotics. So increased rates and risk of C. diff and, side effects from antibiotics themselves. So definitely highly encourage you, if you have a patient who is coming in with altered mental status, to please look for alternative causes, especially if they don't have any systemic features of an infection. So this is an algorithm from a New England Journal article of acute pyelonephritis. And so it's a nice algorithm. So we'll start here. So you have someone that you have a suspicion for that they have a pyelonephritis. So indications for, getting imaging, if they have a GFR decrease of less than 40 per minute, they have a known or suspected kidney stone, a urine pH greater than 7, then yes, you should obtain imaging, a CT or ultrasound. And that's why it's very important when we are evaluating these patients that you should ask them about any history of
You
kidney
put it
stone.
in the pantry already?
If no, then, you know, indications for immediate admission. So if they have sepsis, septic shock,
Kathy, can you sign for this? Because
fragile condition, if they're immunocompromised host, unstable, or they have a tenuous social issues, these would be indications for admission, immediate admission. If no, then if there's clinically significant hypovolemia, they're moderately ill, they have nausea and vomiting, then maybe they're probably more appropriate for ops. If not, then they can be discharged home. So if they do meet this and they are coming to the ops unit to see you guys, then you start antibiotics, IV fluids, other medications. And if they're having persistence in these symptoms, ongoing nausea, vomiting, ongoing hydration, ongoing hemodynamic instability, and they're too ill or unwilling to go home, then that would be the time for you to admit them. If not, if everything is improving, then that would be the time for them that you would be able to step them down to oral therapy and discharge them home. So coming to empiric management of pyelonephritis. So if you have someone who has a complicated urinary tract infection or pyelonephritis, and coming on this side, outpatient management or clinical decision unit. So due to our local rates of E. coli resistance, we do recommend to obtain a urine culture. And then at that time, you can start ceftriaxone, 1 gram of ceftriaxone IV, or gentamicin. But I would say if they don't have any allergies to beta lactam, such as ceftriaxone, I would just do ceftriaxone. And the same thing on this side, if a patient is hospitalized, getting a urine culture, starting ceftriaxone. If they have a history of an ESBL in the past year, and they have a low risk for Pseudomonas, usually Pseudomonas we see in patients who have catheters, or if they had pseudomonal urine infections in the past, then ertapenem alone should be fine. If they do have a risk for Pseudomonas, then cefepime would be appropriate to start empirically. And then alternatives, if someone has allergies such as astrienam, or other alternative is ampicillin plus gentamicin. And then once the culture susceptibilities come back, we can tailor them to oral therapy. And so when do you step down to oral? So once a patient has improvement in clinical symptoms, such as they've defervesced, their dysuria or abdominal pain or flank pain that they may have come in with is resolving, and they're tolerating oral intake, then you can de-escalate to one of these antibiotics over here for a total of 7 days. And this is including if they have bacteremia. So recent studies have shown that looking at 14 days versus 7 days of bacteremia associated with pyelonephritis, patients who received 7 days did just as well as patients who received 14 days in regards to mortality, relapse of infection, hospital stay. So it's now recommended that if a patient, even if they have a bacteremia and they have associated with pyelonephritis, that 7 days is just as good as 14 days. So the preferred therapy, and here we have the E. coli, like the percent of E. coli resistance. So Bactrim will be a preferred therapy. If someone has oral therapy will be good. If they don't have a sulfur allergy, there's no issues with potassium, hyperkalemia, no issues with kidney function, then Bactrim is an excellent choice. If you have someone who has enterococcus in the urine, which I'm quite sure some of you have seen before, amoxicillin is good, will be great for that. And then I would say Cipro. So nitrofurantoin, as you can see here, do not use in pyelonephritis or prostatitis. So in this case, you would not use nitrofurantoin. So if I can't use Bactrim, then I like to use Cipro, unless if there is no contraindication to that. Both Cipro and Bactrim have very good bioavailability, so it gets into the kidneys and into the bloodstream very well. So those are my first two choices in these type of situations. If I can't use Cipro, if I can't use Bactrim, then a beta-lactam such as Augmentin or cefuroxime. Cefuroxime is a second-generation oral cephalosporin. Cefpodoxime, which is a third-generation oral cephalosporin, will be good alternatives as well. So for cystitis and oral antibiotic therapy, the preferred therapy is you can use nitrofurantoin in this case for if you're just treating a cystitis, and it's recommended, for 5 days if it's uncomplicated. But if you're dealing with a complicated cystitis, then 7 days. You can also use Bactrim, and the duration, if it's uncomplicated, 3 days. If it's complicated, 7 days. Phosphomycin can also be used. It's less effective than nitrofurantoin. The problem with phosphomycin, as some of you may know, it's very expensive, and a lot of insurance companies don't cover. We have a hard time trying to get approval of the phosphomycin. So it's an alternative. And of note, for patients who have ESBL cystitis, and you don't want to send a patient home on IV ertapenem, for example, then phosphomycin is a good alternative to treat, and it's oral. And based on our susceptibilities here, is typically 91% susceptible to ESBL organisms, which is very, very good. Other alternatives, you have Cipro, which is also similar to Bactrim, 3 days uncomplicated, 7 days if it is complicated. And again, if you notice, in comparison to oral beta-lactams, it's 7 days irregardless. And that is due to the fact that Cipro and Bactrim have such good bioavailability. They get into the urinary tract and in the bloodstream so well that you only need a few days of the antibiotic if it's for uncomplicated infection. So 3 days is good enough. In comparison, if you're going to use Keflex, it's a longer course of therapy because of the bioavailability of the medication. So coming to the last topic, I want to talk about pneumonia and the management of pneumonia. So just again, to start off with some definitions. So pneumonia is defined as an inflammation of the pulmonary parenchyma that's caused by an infectious agent. So that could be viral or bacterial. I'm going to focus more on bacterial, not so much on viral pneumonia. So community-acquired pneumonia, or CAP, as we commonly refer to it, is an infection of the pulmonary parenchyma acquired outside of the hospital. Hospital-acquired pneumonia is the pneumonia that's acquired after being in the hospital for 48 hours or more. Of note, HCAP, or healthcare-associated pneumonia, is no longer used because it was overly sensitive and it led to increased inappropriate broad-spectrum antibiotic use. So HCAP used to refer to as if a patient had been a dialysis patient, or if a person was in a nursing home, they would fall under the HCAP, and they were considered to be at risk for pseudomonal and MRSA pneumonia. However, the recent literature and the recent guidelines have gotten rid of HCAP because it was just too sensitive, and we were giving too many patients vancomycin and pseudomonal coverage inappropriately. So coming to the microbiology of bacterial pneumonia, strep pneumo is still the most common cause of bacterial pneumonia. Other causes is Haemophilus influenza, Moraxella. Staph aureus can cause pneumonia. Group A strep, gram-negative, such as E. coli, Klebsiella. And then over here, atypical, and what we mean by atypical bacteria is bacteria that are difficult to grow on routine culture. So Legionella, Mycoplasma pneumonia, Chlamydia pneumonia, Chlamydia cystic, and Coxiella brunetti. Cysticercosis is, often this is associated with like birds, and Coxiella is associated with farm animals. So it's rare to see Coxiella brunetti, but it is an atypical bacteria. But this is very rarely seen here in the U.S. So, patients who have a bacterial pneumonia often present with cough, with or without sputum production, dyspnea. They may have chest pain, oftentimes pleuritic chest pain, or chest pain with taking a deep breath, fevers, chills, fatigue. On radiology, they have consolidations, lobar consolidations, or they may have infiltrates. Gram staining culture it is recommended to obtain a gram staining culture in patients who have severe CAP, or they're being empirically treated for MRSA, or empirically being treated for Pseudomonas, or previously infected with MRSA, or previously infected with Pseudomonas, and were hospitalized that received IV antibiotics within the last 90 days. I'm saying all that to say is that most of the time, a lot of the times patients won't have any sputum to produce for us. And if you are able to obtain a sputum, only 30% of the time will the sputum culture grow anything. Most of the sputum cultures that patients provide are usually oral contaminants, so they're really not that helpful. And it's not recommended to routinely obtain sputum cultures unless the patient meets these criteria. And that is the same thing with blood cultures. So unless a patient meets the criteria that's stated above for sputum cultures, it's not recommended to routinely obtain blood cultures in patients who are coming in with a community-acquired pneumonia, or for that matter, a hospital-acquired pneumonia, because they're oftentimes they're negative, not helpful, and most of the time we see if something is positive, it's usually a skin contaminant, coag-negative staph, and then that leads to inappropriate vancomycin use and repeating blood culture. So we're utilizing more resources. So if a patient doesn't have severe CAP, they're not febrile with hemodynamic instability, it's not recommended to routinely get blood cultures on these patients. We should routinely check for urine Legionella antigen. And you'll be surprised how often that has been missed, and where we have picked up patients who actually have Legionella, who coming in with severe CAP in the ICU, or even here on the GPUs where they're admitted and a Legionella antigen wasn't checked, and after they're admitted, it's checked and it's found to have Legionella pneumonia. So now, since we're in influenza season, if a patient is coming in with a pneumonia, community-acquired pneumonia, we should be checking for flu PCR. And the ER, they're also, everyone is getting checked for COVID. So I kind of left that out because there is routinely being done. And hopefully you don't have any COVID patients coming to the observation unit. So when it comes to procalcitonin, the guidelines for hospital-acquired and the guidelines from community-acquired pneumonia that came out last year, they recommend that use your clinical judgment and radiographic evidence to determine if a patient needs antibiotics or not, and do not rely on a procalcitonin. So, and me personally, I'm not a huge fan of the procalcitonin, and oftentimes I base my my judgment, or as far as if I'm going to treat someone for pneumonia, I base it based off the history, physical, and radiologic examination. So this is a chart of severe CAP. So I was previously telling you that for severe CAP, you need to get sputum cultures and blood cultures. So this is what is defined as severe CAP. So if a patient has either one major criteria or three of these minor criteria, then they meet the criteria for the diagnosis of severe CAP. And as you can see, if it's a respiratory rate greater than 30, a PF, PaO2, FiO2 ratio less than 250, multilobar infiltrates, confusion, uremia, leukopenia, thrombocytopenia, hypothermia, hypotension, and then major criteria if they come in septic shock, blood pressors, respiratory failure requiring mechanical ventilation. So the pneumonia severity index. So the pneumonia severity index is a scoring system that is used to for prognosis in patients with community-acquired pneumonia, and also it is used as far as determining whether a patient should be admitted or they can be managed as an outpatient. And the current guidelines actually recommend the pneumonia severity index over using the curve 65 because it is more accurate than the curve 65. And I put down here, this came from an algorithm that if a patient meets a class 3, then it's recommended to either manage as an outpatient or with a brief observational stay if you calculate them to have a class 3. I'm not sure if our Epic, I know our Epic has built-in scoring systems. I'm not sure if this is one of them or not. But it's helpful in regards to prognosis. So the higher the score, the higher the 30-day mortality, as you can see. And typically the higher the mortality, usually the higher the acuity of the patient. So if someone is coming in with a score of 4 or 5, they're usually being admitted to the intensive care unit. So coming to treatment of community-acquired pneumonia in the inpatient. So this is if someone is coming in and you want to empirically start them on antibiotic therapy. Again, we're trying to cover for streptococcal pneumonia because this is the most common cause, H. influenza, our atypicals, mycoplasma, chlamydiophilia, and Legionella. So we recommend either using Amsulbactam or Unicin plus doxycycline, or you can use Amsulbactam plus azithromycin. Same thing, ceftriaxone plus doxy, or you can do ceftriaxone plus azithromycin. If a patient has a severe beta-lactam allergy, meaning a severe penicillin or cephalosporin allergy, then oral moxifloxacin would be appropriate. Also, there's a new medication called lefamulin that can be used for a patient who has a severe beta-lactam allergy, and I'll discuss a little bit more about lefamulin. And for ICU patients with suspected MRSA and CAP, then at that time we can add we can broaden our antibiotics out to add vancomycin or linezolid. So I wanted to also point this out as well, because this is something new that came out of the updated community-acquired pneumonia guidelines last year. And that is routine anaerobic coverage is not necessary for aspiration pneumonia. And that is because, when we're thinking about aspiration, we're thinking of someone aspirating gram-positive oral fluoro anaerobes, such as Peptostreptococcus being the most common. Majority of the oral anaerobes are penicillin susceptible. So your Unison or your ceftriaxone will be more than enough to cover those organisms. So adding metronidazole or clindamycin or putting add metronidazole and clindamycin or necessarily adding any type of anaerobic coverage is unnecessary unless someone has a lung abscess or an empyema. So this was something that was, this is a new recommendation that came out last year that I wanted you guys to be aware of, that if you have someone who's coming in with aspiration pneumonia, that you don't necessarily have to routinely add flagyl or clindamycin. So just to talk a little bit about lefamulin. So lefamulin is a novel antibiotic, and it works by inhibiting the bacterial protein synthesis by binding to the enzyme peptidyltransferase on the 50S bacterial ribosome. It was FDA approved on August 19th, 2019 for the treatment of community-acquired pneumonia in adults. It's available both IV and oral. So the most common side effect that's associated with this medication is liver enzyme elevation, nausea, vomiting, diarrhea, and you can also have some injection site reactions. Of note, this medication can cause QT prolongation, just as fluoroquinolones can. And for Henry Ford, we have positioned this medication as an alternative to a fluoroquinolone. So let's say if a patient has an allergy to beta-lactams or like a severe penicillin allergy, and sometimes we have patients who have allergies to fluoroquinolones or intolerance to fluoroquinolones, then this medication, lefamulin, would be a good alternative in that sense. And right now, we're only using it in patients who will be admitted to the GPU. And also, before we use this medication, we would need to send off a test script to make sure that this medication is going to be covered and that the patient will have access to this medication because it's expensive. It's a new medication. And some insurance companies will require prior authorization. So before you start this patient on this medication, or if you're thinking about putting this patient on lefamulin, you please send off a test script. So when do we step down from IV therapy to oral therapy in someone who's coming in being treated for a CAP? So once a patient is afebrile for 48 to 72 hours, and they have no more than one CAP-associated sign of clinical stability. So meaning that, if they came in with, cough, or they had some chest pain, or if they came in and it was tachycardic. So we would like for, those symptoms to be resolving as well. And they should be able to tolerate oral medications. So if they're meeting those criteria, then that will be the good time to step them down to an oral regimen. And so what are the oral regimens that we could step them down to? So if a patient doesn't have no real comorbidities, such as chronic heart failure, lung disease, liver or renal disease, diabetes, or alcoholism, which is probably not going to be that many patients, then doxycycline is preferred. Of note, azithromycin alone, we don't recommend using that here in Detroit. And that's the reason why is that 40% of strep pneumo isolates that have been isolated here in Detroit and here at the Henry Ford Health System, 40% of them are resistant. So, which is extremely high. So I would not recommend giving somebody a Z-Pak for CAP due to that, for that reason. And our preference would be, if you're going to use something monotherapy, do doxycycline. So if someone does have comorbid conditions such as chronic heart disease, lung disease, liver disease, diabetes, probably majority of our patients, then a beta-lactam plus doxycycline, or you can do a beta-lactam plus azithromycin. And what I mean by beta-lactams, we're talking about amoxiclav or Augmentin, cefuroxime or cefpodoxime, plus either azithro or doxycycline. Azithro and doxycycline because of they have atypical coverage, and the beta-lactams for the strep pneumo coverage, and Haemophilus influenza and Moraxella is also covered by those beta-lactams as well. If someone has a severe beta-lactam allergy, they're allergic to these medications, then moxifloxacin alone, or levofloxacin alone. Or again, you can use lefamuline alone. So lefamuline also has, in addition to covering strep pneumo and your typical bacteria, it also has atypical coverage, including Legionella. So you can use it as a monotherapy as well. And as far as duration of therapy, if someone doesn't have lung disease, such as COPD, and they have, prompt clinical response, meaning they respond within, 48 hours or so, then 5 days is good enough. If they have a delayed response, or if they have COPD or some other structural lung disease, such as, fibrosis, interstitial fibrosis, then, 7 to 10 days of therapy is recommended. So just want to touch base quickly about empiric therapy when targeting MRSA and Pseudomonas pneumonia. So before we, routinely, start putting everyone on vanc, Zosyn, vanc, cefepime for a hospital where we suspect to be like a hospital-acquired pneumonia, we suspect that this patient is at risk for Pseudomonas or MRSA pneumonia, we should look and see, do they have the risk factors for resistant bacteria, which the risk factors would be hospitalization for 48 hours during the previous 90 days, a known respiratory tract, they're colonized with MRSA or Pseudomonas previously, if you look back at previous respiratory cultures. If the patient has received IV antibiotics in the previous 90 days, or if they've had a hospital-acquired pneumonia, meaning that they had pneumonia that occurred 2 or more days after hospitalization, or ventilator-associated pneumonia. In that case, we would recommend, or we do recommend, to empirically start the patient on vanc, cefepime, or vanc linezolid. And I just also want to come back and point out that you don't see anything about HCAP anymore, about patients being in nursing homes or being in hemodialysis, that all has been taken out of the guidelines. I do want to talk about when do we de-escalate in these patients? It's very difficult to know. There's really no guidance. And it is recommended that if you empirically start someone on vancomycin or cefepime, or you're targeting MRSA or Pseudomonas, that you should obtain the cultures, and then based on the culture results, you should try to de-escalate the antibiotics to something monotherapy like a moxifloxacin, or if you can do something like augmentin plus doxy. So another alternative to that, let's say if you have a patient, like the cultures are negative, you can't obtain any cultures, doing an MRSA culture swab of the nose to see if this patient is colonized with MRSA. If they're not, then we can, drop the vanco or don't worry about targeting MRSA. And then in that case, something like moxifloxacin, oral moxifloxacin to finish up a 7-day course would be appropriate. So, just to finish up, I just want to leave you guys with a few take-home points. So, first point, shorter is better. Recent JAMA article that came out has shown that, given longer courses and more antibiotics is actually probably more harmful than helpful. And so shorter courses have been shown to be just as good as longer courses without having the potential risk of developing C. diff, the potential risk of causing resistance, the potential risk of causing side effects due to the antibiotics themselves. So if we can use a shorter course, a 5-day course, a 3-day course, a 7-day course, then we should target and aim for that. Also, the next point that I would like for you guys to take home with you is that in non-purulent cellulitis, which is probably the most common or the most type of cellulitis, the most common skin infection that we see, is that majority of these non-purulent cellulitis cases are due to streptococcus and MSSA, and does not routinely require antibiotics to target an MRSA. So we don't have to routinely start vancomycin on every patient who has a non-purulent cellulitis. So if they don't have risk factors for MRSA that we talked about, or they don't have previous history of having cultures being positive for MRSA, or if you do your MRSA nasal culture and it comes back negative, then using penicillin or cephalosporin is actually better and will be warranted in that case. Also, I also want you guys to remember that when you have someone that's coming in with a skin structure infection, that you always have to assess for necrotizing fasciitis, as this is considered a surgical emergency. And this is something that we do not want to miss in these patients. Also, asymptomatic bacteria does not require antibiotic therapy in non-pregnant patients. So in pregnant patients, that is the one population where someone who has asymptomatic bacteria, it is recommended to treat. Outside of that, if a patient doesn't have any symptoms and they have bacteria in their urine, please don't give them antibiotics. Most patients presenting with altered mental status do not have a UTI. So it's important for us to assess for other causes, like is it due to dehydration, polypharmacy, or some other non-infectious etiology. Also, aspiration pneumonia does not require routine anaerobic coverage. So again, oral flora that is typically the cause of aspiration pneumonia are penicillin susceptible. So we do not have to add metronidazole or clindamycin for patients who have an aspiration pneumonia. unless it's associated with some sort of lung abscess or empyema. HCAP is no longer used. So if you are concerned about MRSA and Pseudomonas, please assess for the risk of MRSA and Pseudomonas as we talked about, and then start your antibiotic coverage appropriately based on the risk assessment. I would like to thank you for your time. I'm happy to take any questions.
Yeah, thank you so much, Dr. Williams, for this lecture. We'll just open up for any questions from anybody online. I think there were a couple of questions on the chat window. One was from Dr. Pillai, who was our hospitalist. He was asking, which criteria is being used to define sepsis? Are we using the SIRS criteria or the SOFA criteria?
So I would say in the ER, they are the Q-SOFA is the criteria that we are using for sepsis, and we do have if I do recall, we do have a built-in SOFA score that's built into the Epic, and I remember that because of the when we were doing research studies with COVID, we were using the SOFA score that was being calculated by the ER as part of our research.
Okay. Any other questions? I think another question was about necrotizing fasciitis, the scoring that is used for necrotizing fasciitis. How common is that? Is that something you use routinely on seeing cellulitis?
Sorry, can you repeat the question one more time?
The Lindreck score for
yes.
Necrotizing fasciitis. Yes. How commonly is that
used? It's more so clinical judgment, but if there is any type of clinical judgment in radiology, most of the time patients who have necrotizing fasciitis is pretty noticeable. They present and it's not that subtle, but there have been some occasions where it's more subtle, especially in some of our immunosuppressed patients, like some of my transplant patients, solid organ transplant, because they're on their immune suppression kind of blunts their response. So in that case, and you may not see, for example, edema in the fascial layer, or you may not see subcutaneous gas, but you still kind of have a suspicion for necrotizing fasciitis, then that can be used as an adjunct to your clinical and radiologic findings. I wouldn't say that it's used often, but it can be pretty helpful if it's a very subtle case. I hope that answered the question. Hello? Can you hear me?